Clinical motor weakness follows a predictable mechanical failure at a precise, localizable point along the neural circuit. This map shows the four descending vertical tiers: the command center, or upper motor neuron, the transmission wire, or lower motor neuron, the neuromuscular junction, and the muscle. The bottom legend outlines our diagnostic rules: a brake, a wire, a synapse, and an engine. The physical characteristics of a weakened limb, whether it is stiff and jumping or floppy and completely unresponsive, act as exact anatomical coordinates. They point directly to which of these four systems is broken. We are going to trace this entire pathway from the cortex down to the muscle fiber. By deliberately breaking the physiology at each tier, we can observe the exact physical signs that result. By treating the nervous system as an integrated electrical circuit, we can isolate the specific component responsible for the failure. We begin at the top, with the upper motor neuron pathway originating in the precentral gyrus of the brain and descending through the central nervous system. Box 1 details an ischemic stroke. Halting ATP causes sodium-potassium pumps to fail, triggering glutamate excitotoxicity, calcium influx, and neuron death. The command pathway is severed. Over in Box 3, multiple sclerosis attacks central myelin. Without insulation, saltatory conduction fails, and the signal stops entirely. Normally, the brain acts as a constant brake pedal. It continuously sends descending signals that suppress and regulate spinal stretch reflexes, keeping them under tight inhibitory control. When a stroke or MS snaps that connection, descending inhibition is lost. The reflex arcs become wildly overactive. This disinhibition produces a very specific clinical picture. Muscle tone rises, causing velocity-dependent spasticity. Reflexes become hyperactive, and pathological signs like a positive Babinski reflex appear. Brain and central cord lesions remove the neurological brake, resulting in an overactive, uncontrollably tight limb rather than limpness. Moving down the anatomical axis, the signal reaches the ventral horn of the spinal cord and enters the peripheral nerves. This is the territory of the lower motor neuron. Box 2 shows a spinal cord lesion. Upper motor neuron signs appear below the injury, while lower motor signs appear precisely at the lesion. Box 4 highlights ALS. It destroys both systems simultaneously, mixing upper motor spasticity directly with lower motor fasciculations and atrophy. Moving entirely out of the spinal cord, we reach the peripheral nervous system. In Guillain-Barré syndrome, post-infectious antibodies attack the Schwann cell myelin surrounding these peripheral wires. Without that myelin sheath, the motor action potential physically cannot travel down the exposed wire. The signal fizzles out before reaching the muscle. The resulting signs are purely lower motor neuron. The patient develops ascending weakness and flaccid paralysis. Because the muscle loses its direct trophic support from the nerve, it rapidly atrophies. Reflexes completely disappear in these lesions. A spinal reflex requires an intact sensory loop going up to the cord and an intact motor loop coming back down. If the peripheral wire is cut, the loop is broken. Unlike the tight spasticity of central disinhibition, severing the peripheral cable results in total communication failure. You are left with a floppy, reflex-dead limb. At the very end of the peripheral nerve, we zoom in to the microscopic gap between the nerve ending and the muscle fiber, the neuromuscular junction. Under normal conditions, acetylcholine is released across this gap. It binds to nicotinic receptors on the muscle end plate, triggering an influx of sodium that generates an end plate potential. Box 6 shows myasthenia gravis, a postsynaptic failure. Autoantibodies destroy nicotinic receptors. Less acetylcholine binding means less sodium enters, causing rapid fatigue, classically in the eyes. In Box 7, botulinum toxin cleaves presynaptic snare proteins. Acetylcholine cannot release, causing descending flaccid paralysis. Neuromuscular junction diseases create unique patterns of weakness, either predictable fatigue or descending paralysis, because they cause signaling failure strictly across this microscopic gap, leaving the actual nerve and central reflexes intact. Modern medicine uses pharmacological paralytics to hijack these exact same chemical bottlenecks at the neuromuscular junction. Box 8 shows succinylcholine. It binds the receptor but isn't broken down, causing a continuous sodium influx. This massive depolarization initially causes fasciculations, but soon sodium channels inactivate, leading to total paralysis. Rocuronium, in box 9, is a non-depolarizing antagonist physically blocking acetylcholine entirely. Because the channel never opens and zero sodium enters, the muscle experiences immediate paralysis without any initial twitches. Whether the junction is sabotaged by a bacterial toxin, an autoantibody, or a syringe, breaking the spark plug guarantees motor failure, even if the brain's command signals are firing perfectly. The final destination on the motor axis is the structural machinery of the muscle fiber itself. In myopathies or rhabdomyolysis, detailed here in box 10, the neural wiring is intact. The neuromuscular junction fires correctly, the action potential arrives, but the physical sarcolemma, the structure of the muscle, is ruptured. When the contractile machinery is destroyed, the patient presents with proximal weakness and severe muscle pain. Crucially, because the nerves are untouched, sensation and spinal reflexes remain normal. This rupture has severe systemic consequences. Damaged muscle leaks myoglobin directly into the bloodstream, which can rapidly overwhelm the kidneys and trigger acute kidney injury. Engine failure looks distinctly different from neurological weakness. The entire electrical command network is fully operational, but the muscle lacks the physical integrity to contract. This map lays out the entire anatomical continuum, tracking the motor signal from the cerebral cortex down through the peripheral nerves, across the synapse, and into the microscopic muscle fiber. Spastic limbs with brisk reflexes mean upper motor neuron brake failure. Floppy limbs with absent reflexes mean the lower motor neuron wire is cut. Fatigable weakness indicates a broken neuromuscular synapse. Weakness with severe pain and elevated kinase means a shattered muscle engine. The nervous system operates through a rigid structural anatomy. Mastering this circuit provides a framework where diagnosis follows directly from the physical evidence.